Preeclampsia is a significant cause of maternal and perinatal morbidity and mortality. 1/3 of all preeclampsia cases require preterm delivery, and its association with fetal growth restriction and prematurity often leads to lifelong consequences for the child. Furthermore, mothers affected by preeclampsia are 2 to 5 times more likely to develop hypertension, cardiovascular, and cerebrovascular disease in the future when compared to mothers who do not have preeclampsia in their pregnancies. In recent years, significant amount of research has been dedicated to elucidate the pathophysiology of the disorder, develop methods in identifying women at risk through the use of predictive models, and investigate possible preventive strategies to reduce the incidence of preeclampsia. A long-held belief of the underlying pathophysiology of preeclampsia is that it is a two-stage process in which multiple factors may cause inadequate trophoblast invasion that leads to shallow placentation. Reduced placental perfusion leads to hypoxia, and the second stage, which is characterized by oxidative stress that stimulates the release of inflammatory cytokines, anti-angiogenic factors, and microparticles, causing widespread endothelial dysfunction, inflammation resulting in the clinical manifestations of preeclampsia. Many interventions have been studied for the prevention of preeclampsia. Aspirin, at a dose of less than 300 mg, is known to inhibit the COX-1 enzyme and reduce inflammation and platelet aggregation. So, could aspirin prevent preeclampsia? Aspirin is one of the oldest medications that is still in widespread use. Aspirin-related compounds were isolated from the willow tree, and reports of willow bark use can be found in Egyptian papyrus scrolls, with compilations of medical texts dating back to 1534 BCE. Around 400 BC, Hippocrates also utilized extracts from the willow tree and its leaf tea to treat headache, pain, and fever. In 1828, the active ingredient of the willow bark was extracted and it was called salicin. A few years later, in 1853, sodium salicylate was treated with acetyl chloride to produce acetylsalicylic acid, and the first aspirin tablets were industrially produced in 1915. The use of aspirin became widespread during the 1918 flu pandemic, and in the 1960s, the first studies on aspirin use on the prevention of myocardial infarction were published. The first possible link between the use of aspirin and the prevention of preeclampsia was suggested by a case report published in 1878, describing better outcomes with daily use of aspirin from mid-trimester in the third pregnancy of a woman with 2 previous pregnancies severely affected by preeclampsia and fetal growth restriction. Since then, many studies have evaluated the potential role of aspirin in preventing preeclampsia. Aspirin at doses below 300 mg selectively and irreversibly inactivates the COX-1 enzyme, suppressing the production of prostaglandins and thromboxane, and inhibiting platelet aggregation. The mechanism by which aspirin prevents preeclampsia is, however, unknown, and proposed mechanisms are largely speculative and based on in vitro research, which is consistent with the lack of understanding of the disease pathophysiology. Possible mechanisms that have been proposed include improvement in the placentation process, which is supported by the fact that early initiation of therapy shows a more prominent reduction in the risk of preeclampsia, inhibition of platelet aggregation and its antithrombotic effect, thereby leading to lower levels of placental infarct, and anti-inflammatory effects and endothelial stabilization. In vitro research with human choriocarcinoma-derived cell line treated with serum from preeclamptic women and aspirin suggests that the drug modulates cytokine secretion, reduces apoptosis to levels seen in normotensive serum-treated trophoblastic cells, upregulates trophoblast PLGF production, and prevents premature trophoblast differentiation, commonly observed in preeclampsia. These findings, however, have not been confirmed in human in vivo studies. Nonetheless, the beneficial effect of aspirin on preeclampsia is now evident. In the first randomized trial evaluating the effect of aspirin on placenta-mediated complications, Bovis et al. Randomized 102 women at high risk of preeclampsia and fetal growth restriction, mainly based on their obstetric history, to receive daily aspirin at 150 mg and dipyridamole at 300 mg from 12 weeks of gestation or usual care. There were 6 cases of preeclampsia, 5 of perinatal death, and another 4 of fetal growth restriction in the control arm, and none of these events occurred in the treatment arm. Numerous randomized trials followed in the next few decades, with inconsistent results and conclusions, largely explained by a high degree of heterogeneity regarding the selection of trial participants, baseline risk of the included women, dose of aspirin, gestational age of prophylaxis initiation, and preeclampsia definition. A large randomized trial performed in 1994, named Collaborative Low-Dose Aspirin Study in Pregnancy, CLASP, included more than 9,000 women at risk of preeclampsia or fetal growth restriction due to medical history, as well as pregnancies already diagnosed with these complications. Treatment with a daily dose of 60 mg of aspirin, initiated between 12 and 32 weeks of gestational age, was considered safe but did not lead to a reduction in preeclampsia rates. Interestingly, it was observed that there was correlation between rates of preeclampsia and gestational age of delivery. The lower the gestational age, the lower the rates of preeclampsia. In 2007, ASPRE et al. Published an individual patient data meta-analysis on the effects of antiplatelet agents, including 24 randomized control trials with aspirin alone, on the incidence of preeclampsia. A modest 10% risk reduction was identified. It is important to note that 15 definitions of preeclampsia were used in different included trials. In most studies, trial medication was given at doses lower than 100 mg, and in 59% of the included pregnancy trial, medication began after 20 weeks. A series of subsequent meta-analyses of aggregate data has demonstrated that aspirin is highly effective in reducing preeclampsia rates if initiated before 16 weeks of gestational age, but confers no beneficial effect when started after 16 weeks. The effect of preeclampsia rates is mainly due to a reduction of the severe and preterm forms of the disorder, with no significant beneficial effect on term preeclampsia, and there is a dose-response effect when aspirin is initiated before 16 weeks of gestational age. These later meta-analyses have been criticized because of the use of aggregate data, which may overestimate the effect size of aspirin as compared to individual patient data meta-analyses. The inclusion of a small number of heterogeneous studies and the fact that the subgroup that received aspirin before 16 weeks of gestation is likely to have a higher risk profile than the subgroup of women who received aspirin after 16 weeks. Due to the conflicting results and significant heterogeneity of previous studies, and informed by the results of the aforementioned meta-analyses, demonstrating that aspirin is highly effective in reducing preeclampsia rates if initiated before 16 weeks, the ASPRE trial was proposed. Based on previous data suggesting that approximately 30% of women are non-responsive to effects of aspirin at a daily dose of 81 mg, but only 5% are non-responsive to its effects at a daily dose of 162 mg. High-risk women were randomly and blindly allocated to receive 150 mg of the trial drug daily or placebo from 11 to 14 weeks of gestation until 36 weeks, or delivery, whichever occurred first. Aspirin was given at bedtime based on a previous chronotherapy trial including 350 high-risk women and comparing different administration times, suggesting that the beneficial effects are dependent on the time of administration, with better regulation of ambulatory blood pressure when taken at night. Innovatively, high-risk women were identified by means of a combined algorithm that takes account of maternal characteristics, medical and obstetric history, biophysical and biochemical markers. Women with a predicted risk at or higher than 1 in 100 were deemed high risk for developing preterm preeclampsia, resulting in a screen pass-through rate of 11%. Eventually, over 1,700 high-risk women were recruited from 13 hospitals across 6 European countries, and treatment with aspirin was demonstrated to reduce the rate of preterm preeclampsia by 62%. Of note, there was a non-significant trend of greater reduction in the rate of preeclampsia the earlier the gestational age at delivery, and no significant reduction in the rate of term preeclampsia was observed. What is unclear to us is whether aspirin truly stops early onset preeclampsia from happening, or whether aspirin reduces the severity of the disease, leading to a delay in onset and therefore delivery. The diagram on the left shows the distribution of gestational age at delivery with preeclampsia in the placebo and aspirin groups. This demonstrates that in the aspirin group, the incidence of early deliveries with preeclampsia is reduced. In addition, aspirin appears to have the effect in delaying the gestational age at delivery with preeclampsia. According to the diagram on the right, the aspirin-related delay is greater for earlier than later preeclampsia. A secondary analysis of the ASPRE data demonstrated a consistent effect size within subgroups according to recognized risk factors of preeclampsia, except in the subgroup of women with chronic hypertension, where no indication of beneficial effect was seen, possibly due to pre-existing endothelial dysfunction or pre-established suboptimal cardiovascular dysfunction. Additionally, as expected, the beneficial effect of aspirin was clearly associated with good adherence to treatment. At 90% compliance, The effect size of aspirin is even higher at 76% and can reach 90% when the high-risk woman does not have a history of chronic hypertension. Another secondary analysis of the ASPRE data demonstrated that neonates from the aspirin arm who required admission to the Neonatal Intensive Care Unit had a significantly shorter length of stay than that of neonates from the placebo arm who needed admission. This finding was primarily driven by a significant decrease in the rate of preterm delivery before 32 weeks of gestation, mainly because of the prevention of early onset preeclampsia. With regard to number needed to treat, to prevent one case of preterm preeclampsia in singleton pregnancies, we have to treat 38 high-risk cases. This number increases to 69 when our focus is on early preeclampsia. As for preventing small babies, the numbers needed to treat range from 16 to 30. For perinatal death, the number needed to treat is 34. Improving maternal and perinatal health is a development goal, and investing resources in preventing significant public health problems is key to achieve this goal. To date, 5 cost-effectiveness studies have been published on the economic aspects of preeclampsia prevention with aspirin. All studies demonstrate that a screen and treat strategy is highly cost-effective. 3 studies suggest that universal prophylaxis would be the preferred strategy, but did not account for the likely problems of such policy, such as low compliance, side effects, possibly lower treatment effect. Considering the clear benefit of aspirin in reducing the risk of preterm preeclampsia, its low cost and safety profile, some authors advocate for universal aspirin prophylaxis for preeclampsia prevention. It has been suggested that this would be a more cost-effective strategy as compared to the use of aspirin prophylaxis in women determined to be high risk through a process of screening, which has been considered to be rather complex for implementation. Nevertheless, possible benefits of a preventive strategy need to be balanced with potential harm due to hemorrhagic and other adverse events. Benefits of universal aspirin and long-term safety of this strategy have not been adequately studied in randomized trials. Compliance is likely to be lower when aspirin is given to the whole population than when recommended to a select high-risk group of women counseled based on individual risk. Earlier trials in which pregnant women received aspirin on the sole basis of being pregnant or nulliparous demonstrated an increased frequency of bleeding episodes, low compliance with aspirin at only about 50%, and no reduction in the incidence of preeclampsia. Analogously, universal aspirin for primary prevention of cardiovascular events in healthy older adults resulted in a significantly higher risk of major hemorrhage, but did not significantly reduce the risk of cardiovascular disease. Women with multiple pregnancy are at a significantly increased risk of preeclampsia when compared to those with singleton pregnancy, with relative risks of 8.7 and 8.1 for preterm preeclampsia in dichorionic and monochorionic twin pregnancies respectively. When the same combined screening algorithm for singleton pregnancies is applied to twin pregnancies, detection of preterm preeclampsia reaches 99% at the expense of a very high screen positive rate of 75%. Preliminary retrospective data from a single center has demonstrated that the incidence of preeclampsia in twin pregnancies with additional risk factors is significantly lower in those receiving aspirin 150 mg daily compared with 75 mg daily. Furthermore, the issue of aspirin non-response appears more problematic in twin pregnancies, and rates of non-responsiveness to aspirin have been shown to be as high as 65% at a daily dose of 81 mg. A systematic review and meta-analysis of 6 randomized controlled trials with 898 multiple pregnancies have demonstrated a significant risk reduction in preeclampsia and mild preeclampsia, but not severe preeclampsia, with aspirin at doses between 60 and 100 mg. The authors conclude that there is low level of evidence supporting the use of aspirin for the prevention of preeclampsia in multiple pregnancies, and that further studies are required. Aspirin is highly effective in preventing preterm preeclampsia when administered to high-risk women at 150 mg and initiated before 16 weeks of gestation, reducing its incidence by more than 60%. Identification of high-risk women should therefore be performed in the first trimester of pregnancy, ideally with the use of predictive algorithms. Combined screening with maternal factors, mean arterial pressure, uterine artery Doppler, and serum placental growth factor for early prediction of preeclampsia has the capability in identifying a group of high-risk women who are most responsive to aspirin prophylaxis for the prevention of preterm preeclampsia. Additionally, we have learned that daily aspirin 150 milligrams from 11 to 14 to 36 weeks to high-risk women reduces length of stay in the Neonatal Intensive Care Unit by 68%, has no evident beneficial effects in women with chronic hypertension, and that beneficial effect on preeclampsia rates depends upon adherence to treatment. Lastly, more studies on aspirin for prevention of preeclampsia